Now, we know that the AV node can be affected in patients having an acute MI, producing significant conduction defects. But what types of MIs are more prone to AV blocks? Well, let's take a look at today's case to find out. So here's the case. This was a 45-year-old male, a golf course groundskeeper found by his coworkers passed out in the locker room. Now, the patient was a heavy smoker. He's a 2-pack-a-day smoker and non-compliant on his statin medications, and his father had died of an early age in his 40s. Now, the patient appeared ill. He was pale, cool, and diaphoretic, and on examination, his vital signs were abnormal with a systolic blood pressure in the 70s and quite bradycardic in the 40s. And the rest of the examination was fairly unremarkable except for morbid obesity. Now, here's the pre-hospital 12-lead ECG. Go ahead and stop the video here and see if you can come up with an interpretation. And here it is. The ECG checklist, revealed a rate that was bradycardic. The rhythm was regular. Normal axis, and the intervals, well, they're P waves, but they're inconsistent, aren't they? And they don't really correlate with the QRS complexes. ST elevations, well, if you look at the inferior leads, there are in fact some elevations. Q waves, I don't see any pathological Q waves of concern here. No voltage changes suggesting LVH, and there are no abnormal waveforms here either. So let's go ahead and count the QRS complexes out. And if you do so, you get a ventricular rate of about 48 beats per minute, right? They're nice narrow complexes. That's good. And they're regular at about 48. And if you look at the P waves, well, if you look at the P waves, you get a rate, an atrial rate of about 78 beats per minute. Again, there are P waves, but they don't communicate with the QRS complexes, right? So that's a big problem right there. Now, let's go ahead and take a look at the ST segments. And if you look at the limb leads, the inferior leads, 2, 3, and F, there are definitely elevations in these 3 leads. And what's most notable here is the ST elevations in lead 3 is significantly greater than in lead 2, right? So in addition, there are reciprocal changes, ST depressions, and T-wave inversions in both limb lead 1 and AVL. So that kind of goes along with something ischemic. So diagnosis, well, you got it. It's an IMI, an inferior MI with 3rd-degree heart block. Let's review the blood supply to the AV node. Remember, the AV node gets its blood supply from the AV nodal artery, and in about 80% of patients, this artery branches off from the RCA. And about 20% of patients, it comes off the left circumflex, right? So the majority of patients get there. In the majority of patients, the AV node gets its blood supply from the RCA. And just kind of reviewing the anatomy here, remember there are about 7 major branches of the RCA, with the AV nodal branch coming off in about 80% of these patients. So what type of MIs are more prone to AV conduction defects? You got it, inferior myocardial infarctions. So there you go. That's it for this week. Thanks so much for joining up with me this week on Mastery of Medics. Until next week, this is Sush. So long.